Right. Who's presenting the next topic?
Sir, I am presenting, sir.
Go ahead.
Good evening, sir. Today's topic is opioid-free anesthesia. Use of opioids in the perioperative period is associated with respiratory depression, impaired GIT function, postoperative nausea, vomiting, pruritus, and chances of developing opioid addiction and urinary retention. Impaired GIT function is a major issue in bowel surgery, which causes postoperative ileus, which in turn leads to anastomotic leakage. Opioid-induced bowel dysfunction, which pushes the diaphragm upwards, and it causes atelectasis of the lung bases, which leads to the increased work of breathing, which in turn results in respiratory failure and needs reintubation and support. Abdominal distension is the common cause for surgical wound dehiscence. Respiratory depression is most common in patients with sleep apnea, obesity, and chronic obstructive pulmonary disease and upper abdominal surgeries. Opioid-induced postoperative nausea, vomiting is most commonly following upper gastrointestinal tract surgeries, neurosurgery, eye and head and neck surgeries. Opioid-induced gastroparesis, which leads to aspiration during anesthesia induction. Uses of opioid-free anesthesia. Opioid-free anesthesia decreases the common side effects such as sedation, dysphoria, urinary retention, postoperative nausea, vomiting, and delirium. It decreases the chances of threatening side effects like airway obstruction and respiratory depression. Use of opioid-free anesthesia promotes the rapid recovery. And current ERAS protocol recommends the reduction in the usage of perioperative opioids for uncomplicated and rapid recovery. Opioid free anesthesia also decreases the hospital length and decreases the cost of medical care. And postoperative hyperalgesia and tolerance due to neuroadaptation increases the requirement of long-acting opioids and is more relevant with short-acting opioids like remifentanil. Opioids depress the cell-mediated immunity and humoral immunity, which increases the early cancer recurrence. And it is best to avoid opioids in the cancer patients. And aims of perioperative usage. Opioids, it can be achieved by multimodal anti-nociceptive approach, which tolerates the various points of pathways with two or more non-opioid adjuvants, which has additive or synergistic efforts, which allows the reduction in side effects of each and which maintains the hemodynamic status. And there is a Friedberg's triad, which constitutes three parts, where we can measure the brain by bispectral index, which is used to titrate the anesthetic depth, and the other is we have to preempt the pain by giving ketamine and other local anesthetics, and the third one is we have to avoid emetic drugs like opioids. And regarding pain pathways, transmitters like glutamate, noradrenaline, GABA, serotonin, which is involved in BP and heart rate regulation, which opens the pathway for other pharmacological agents acting on ascending and descending pain pathways. The drugs most commonly used in opioid-free anesthesia are ketamine, lignocaine, alpha-2 adrenergic agonists like dexmedetomidine, beta blockers like esmolol, magnesium sulfate, dexamethasone, GABA pentanoids, paracetamol, and NSAIDs. Ketamine, which is the most commonly used drug, which causes better hemodynamic stability. It blocks the N-methyl diaspartate receptors, which decreases the influx of sodium and calcium. It acts as an anti-hyperalgesic and anti-allodynamic effects and anti-tolerance effect. The dosage used is 0.2 to 0.5 mg per kg IV. Alpha-2 agonists, the most commonly used drugs, are dexmedetomidine and clonidine, which are most commonly used in enhanced recovery after surgery protocol. It acts as both central and peripheral anti-nociception. It acts by stimulating the alpha-2 receptors at the substantia gelatinosa in the spinal cord of dorsal horns, which releases the nociceptive release of neurotransmitters. And it in turn hyperpolarizes the adrenergic neurons at the locus coeruleus, which decreases the arousal and blunts the hemodynamic response to nociceptive stimulation. The benefits of dexmedetomidine are it acts as a sedative, hypnotic, anxiolysis, analgesia, sympatholysis, and pain relief, and also acts as a bronchodilator. It decreases the post-op pain intensity and decreases the opioid consumption. And it preserves the airway patency, and it causes the normal sleep architecture. And it is best for the conscious sedation. And it causes no respiratory depression, and it avoids the urinary retention pruritus associated with opioids. And the dosage most commonly used is 0.5 to 1 microgram per kg over 10 minutes, followed by 0.2 to 0.8 microgram per kg per hour infusion. And the most common side effects with dexmedetomidine is bradycardia, hypotension, and dry mouth. And regarding lignocaine, which is amide local anesthetic, it is most commonly used IV to blunt the hemodynamic responses. And it also acts as an anti-inflammatory, analgesic, and co-anesthesia property. And action is by downregulating the neutrophil degranulation, and it also causes the sodium channel blocking property. And the dosage is 1 to 2 milligram per kg loading dose, followed by 1 to 2 milligram per kg per hour infusion. And it is stopped within 1 hour of surgery to prevent the local anesthesia systemic toxicity. And lignocaine decreases the anesthetic and opioid requirements, and it causes faster recovery of bowel function and improved quality of recovery. And the other drug is magnesium. It acts on N-methyl D-aspartate receptors and acts on the calcium influx, and it prevents the central sensitization of the pain path. And the dosage is 30 to 50 milligram per kg IV bolus, followed by 10 to 15 milligram per kg IV infusion. Caution is we are regarding the toxicity, so frequent regular monitoring of magnesium levels to be done. And the side effects is potentiation of neuromuscular blockade and hypotension and other hypnotics. And magnesium is best when combined with ketamine, and it causes better hemodynamic stability. The other drugs are gabapentinoids. The most commonly used are gabapentin and pregabalin. It acts on alpha 2 delta 1 subunit of presynaptic calcium channel, which inhibits the neuronal calcium influx. And it is best used in neuropathic pain. It decreases the release of excitatory neurotransmitters like glutamate substance P and calcitonin gene-related peptide from primary afferent nerve fibers, and which prevents the central sensitization, hyperalgesia, and allodynia. It also has anxiolysis property. The only side effect is excessive post-op sedation in some patients. And the other drug are dexamethasone, which has an analgesic property. If dose is more than 1 mg per kg, it acts as an anti-inflammatory and also as an anti-emetic. The other drug is paracetamol, which decreases the pain sensitivity and opioid requirements. It is administered regularly as part of ERAS protocol and a multimodal anesthesia regimen. And it is contraindicated in CKD patient, and it is used in caution with platelet dysfunction and GIT bleed. The other methods of anesthesia and analgesia are regional anesthesia techniques, which include central neuraxial blockade, paracerebral blocks, and facial plane blocks like serratus anterior block, quadratus block, and erector spinae blocks, and peripheral nerve blocks. And the other method is simple wound site infiltration with local anesthetic, which is highly effective for perioperative analgesia. And the advantages of opioid-free anesthesia are to avoid the side effects of opioids in morbid obese, OSA, COPD, and asthma patients. And respiratory depression and airway obstruction is avoided. And it prevents hypercapnic respiratory failure. And it is also used in complex regional pain syndrome and acute and chronic opioid addiction. And the disadvantages of opioid-free anesthesia are, and the individual components of a multimodal opioid-free anesthesia should be selected carefully based on the individual familiarity and availability and patient characteristics. And potential for awareness is most common if inadequate hypnotic agents is used. And alpha-2 agonists should be used in extreme caution in patients with serious disease and in the elderly patients. Other related contraindications are critical coronary artery stenosis and acute coronary syndrome and uncorrected hypovolemic shock and autonomic dysfunction. Thank you, sir.
Very good. Did you mention anything about NSAIDs You said about paracetamol.
Paracetamol, yes, sir.
Did you mention about NSAIDs like diclofenac, which is also used?
Oh, I didn't mention, sir.
You
I didn't
missed out on that, isn't it?
Yes, sir.
Diclofenac
NSA
is also being routinely used, but there are contraindications, like patients who have any renal disease or bronchial asthma patients. Is NSAIDs contraindicated in all asthmatics?
No, sir.
Why they say asthmatics can have bronchospasm if NSAIDs is used? What is the reason for that?
It causes
It goes into leukotriene pathway, sir. It causes bronchoconstriction, sir.
So which NSAID is safe in asthmatic? Among the various NSAID drugs which are available, like diclofenac, aceclofenac, ibuprofen.
Naproxen, sir.
Ibuprofen is the most safest. Okay, you can still use that in asthmatics also. All other NSAIDs may react and produce a precipitate a bronchoconstrictor effect, and it can potentiate bleeding also because of the antiplatelet effect. Okay? So we have to mention something about that.
Yes, sir.
We'll just go and see what we have to add that.